Good morning, everybody. Welcome. And we would like to extend a special welcome to all of our friends across the East Coast, West Coast, and around the world. Today on the fellow webinar, we are going to be talking about weight recurrence. We have two fantastic speakers who I'll introduce in a second. Just a couple of reminders before we get going. Our ASMBS, we've started now every other month journal club and video session for some more educational opportunities for our fellows. The next one is going to be on December 22nd at 8 o'clock. Please register and join us. It's been really great, lively discussion. Also, submit your abstracts for the 2023 meeting. That window is now open. And please remember to keep your case logs and your requirements for the certificate for ASMBS Fellowship up to date. It helps you at the end of the year, just making sure you have all of your T's crossed and your I's dotted. So without further ado, I will get going. Today, we're going to talk about weight recurrence. We have two people whom I personally love and are near and dear to my heart. Dr. Saniea Majid is joining us from New Jersey. She comes to us by way of Pakistan, where she did her MBBS at Aga Khan University, completed her residency at UMDNJ, and her minimally invasive and bariatric surgery fellowship at UCSD in San Diego. She is the founder and CEO of the Weight Loss and Wellness Center in Livingston, New Jersey, which also has several satellite locations in northern New Jersey. She is the former president, or I guess current going out president of the New Jersey chapter of ASMBS, and has been very active in ASMBS itself, having been the chair of the postoperative weight recurrence task force, the co-chair of the obesity prevention committee, and also an ASMBS Foundation board member. Dr. Majid, thank you for joining us today. Our first speaker is going to be Dr. Matthew Davis, who I know very well. Matthew comes to us by way of Israel, where he attained his Doctor of Medicine. He completed his residency at the Cleveland Clinic, and then the best fellowship in the world, the Minimally Invasive and Bariatric Surgery Fellowship at Duke University. Matthew has also been very active in ASMBS and is the current co-chair of the Post-Op Weight Recurrence Task Force. He is also currently assistant professor of surgery at UTHSC in Memphis, as well as section head in Division of the Division of Bariatric Surgery at Methodist Le Bonheur Healthcare in Memphis, Tennessee. So welcome, Matt, and I will let you take it away.
All right, I think I did that right. All right, good morning, everybody. Thank you very much for the opportunity to present and to provide, kind of a new information on a growing and important subject. And yes, I will concur with Dr. Jane Spangler. I'm sure Dr. Eckhouse will agree as well. It's the best fellowship. So just no disclosures. That was my social disclosure. I do have bias because Dr. Jane Spangler is my surgical mama, as our program likes to refer to some of our leaders, but otherwise no financial disclosure. Still working on that as a new attending. Just as a brief overview, we'll give a definition of weight recurrence. I'm sure for some of the fellows who have joined, that's kind of a new term, and we'll talk specifically about the importance of terminology. We'll talk about workup of weight recurrence, and then surgical options following the lap band and sleeve gastrectomy. So just a little bit about my practice. We are a regional Institute of Excellence, newly minted Institute of Excellence in the past year. For the entire Mid-South region, we have a comprehensive medical surgical practice, really kind of spanning the whole breadth of everything that patients with obesity need post-operatively. And we like to think of ourselves as the highest level of complexity within a 3-hour radius. And that's not to toot my own horn. That's actually the opposite. That means that anyone within 3 hours driving is going to give me a call when they have something complex. Even the local academic centers, because just of the way the region is spread out, there's a handful of people doing bariatric surgery, but there's a tremendous need from a patient and public health population discussion, and therefore there's a lot of patients out there, and there's just not a lot of centers in our region. So it's a big social determinants of health and public health need that we are trying to address. But keep that in mind for you fellows looking to practice and make an impact, and I'm going to touch on that a little bit. So you're probably familiar with a version of this. This is the 2021 data provided by the CDC on self-reported obesity. And if you compare it to 5, 10, 20 years ago, the map just keeps on getting redder and redder and redder, unfortunately. Now we only have one region, DC, which has an obesity rate less than 25%, which 10 or 20 years ago was not the case. So if, again, going out from your fellowship, if you're looking where you want to make the most impact, this is actually a really great map to take a look at. Really, you can see, where regionally you might make the most impact from a public health perspective on obesity, which is really, the pandemic of our times coming off, COVID, which may have impacted 10 to 20%, where obesity is, edging up towards 40%. So just to kind of give you an idea, this is the Mid-South. So as you can see, the circle is mostly filled with shades of red, unfortunately, and therefore representing a significant need. And this is where my practice is, kind of right smack in the middle of it. So we're really trying to make that impact, on a place with maybe the biggest need in America, which by extrapolation could be the biggest need in the entire world. So this is a plug for the Obesity Action Coalition. They have some excellent resources to really try and highlight the impact when you talk about marketing to patients, outreach to patients. And these are the states that I immediately border, being in the southwestern corner of Tennessee. So of course, Tennessee being the 13th state impacted by obesity, but Mississippi being number 1, unfortunately, almost at 40%, and Arkansas being at 9. So we are a significant health need population, specifically for obesity, and that's what we're trying to address. About a third of my volume happens to be revisions, and this is not something that I planned on coming out of fellowship, but this has been, an excellent experiential practice. A lot of lap band revisions, a lot of sleeve revisions, decent amount of bypass revisions, patients who've had bypasses, both regionally and some who've moved to the neighborhood and then needs revisional services. And even some historic surgeries. I'm learning a lot about the history of bariatric surgery. I'm revising a handful of vertical banded gastroplasties. I recently had a non-adjustable band. I'm working up a non-divided bypass as we speak, and then a band over bypass, one of which a couple of years ago actually eroded, and that was quite a fun case right there. So really learning a lot, and it can feel like some days my entire clinic is just revisions. So I tell my office staff at the end of the day that I kind of feel like Bob the Builder. Can we fix it? Yes, we can. So for those of you with kids out there, you may appreciate that more. And then sometimes, I find that revisions are kind of a unique per patient opportunity. Each one, I tell them, is really, especially when we give our seminars and patients ask, I've had the surgery, what happens? And really, it's like its own little masterpiece. And this was just a case about a month ago where, at the end of the day, we just had to give them a fresh start. So this is the entire Roux-en-Y anatomy that we carved out and redid it from scratch. So, you're kind of being a little bit of an artist when you do these sort of revisional surgeries. So let's get back to kind of the topic, weight recurrence. So again, we've used terms like weight regain, insufficient weight loss. Historically, you'll see it all the time in the literature, even, recent literature publications. But weight recurrence is a kind of a new term, and I'll give you kind of a little window onto how that came about. Dr. Majid really has been one of the founders of this task force, and the forces to begin and carry on our work towards this. And she'll, I'm sure, speak more about that as well. But weight recurrence has an incidence of about 20%. About 1 in 5 of your patients will have some sort of weight recurrence. Now, the majority will be a small amount. So, a lot of patients ask, what does the weight come back after a year, 2 years, 5 years, 10 years? And you can tell them that 1 in 5 patients will have some sort of recurrence, but it won't necessarily be significant. It may only be 5 pounds. But as you can see, there's a significant variability in reporting, where some series will report only 9%, but up to 91%. And that's where terminology comes in. And I'll show you how that kind of plays out. But the etiology of weight recurrence is almost always multifactorial. I would say always, but I hate using 100%, but it pretty much 100% is multifactorial. There's never just one reason why patients' weight recurs. It could be due to education, bad education from their previous surgeon, or no education. Let's say they went to Mexico or something where they didn't have any follow-ups. Compliance, which can or can't be, due to patient factors or due to societal factors, environmental factors, and then the social aspect as well. The environment plays such a big impact in weight recurrence. It could be medical, a new diagnosis of hypothyroidism, or they're on a new medication, an antidepressant that increases weight. So something exogenous to the patient. It could be a surgical, whether it's anatomical, their pouch was left too large at the initial surgery, or it dilated. And I know there is variable evidence in the literature whether dilation does really correlate with weight recurrence, but it is a possibility. It's something we see. Retained fundus, both in a sleeve or in a bypass, that extra fundus that should have been resected, or an initially wide or a later dilated gastrojejunectomy can also decrease that restrictive aspect of, for example, a gastric bypass. And then, of course, complications, gastric fistula, where you're unbypassing the bypass, so to speak. So in which case the patient's weight will recur in a lot of cases. And these all do need to be addressed. But the important thing is looking at the patient from a multifactorial way, not really pinning down, even though a patient may come into your office and say, I kind of fell off the horse, or I have this new medical problem on this medication. It's usually not just that. And it's important to really tease out all the aspects that have impacted that. So the concept really of weight recurrence is that we're moving to a more chronic illness model, similar to the oncology world. We use terminology like response rate, so dose response rate to surgery, recurrence of the weight. The fact that obesity is seen as a terminal illness, the patient can be in remission from their obesity. So all these things that it's very commonplace in the oncology world, we're really trying to incorporate into our world as well, to improve the data and reporting of outcomes, but also to improve patient care post bariatric surgery. And it's really a multimodal approach. So things, behavioral intervention, medication, and surgery, all playing parts in the care of the patient with weight recurrence. So this is our recent publication on the definitions and the terminology of weight recurrence. We, as a task force, reviewed the literature related to the outcomes of bariatric surgery, which was approximately 50 articles after an exclusion criteria was applied. We really were focused on the definitions of weight recurrence. And so what was important here is figuring out what were people calling weight recurrence, what were people using, and how were they defining, and therefore how were they categorizing patients. And so, again, new terminology. So why is language important? Why is it that the terminology is that important? Why don't we focus more on, the facts and, the surgery and the medicine? Well, language is important because of this. So after our review, these are the different definitions of weight recurrence. So if a patient comes in and says, I have weight recurrence, or you're sent over a referral for weight recurrence, it could be any one of these definitions because we don't have unified terminology. And as an example, any weight recurrence was used in a study to determine whether patients qualified for interventions after bariatric surgery. So that there's your 91% reporting. BMI above 35. So when you think about it, some of our higher BMI patients may never get below a BMI of 35. So is that a good definition of weight recurrence? In some patients, yes. In some patients, not. But that can't be the standard. And then something simpler, easier, more common, greater than 10 kilograms or 22 pounds from their nadir weight, that could be important in some patients, but in a patient who's lost 250 pounds, is 22 pounds really that significant to necessitate an intervention? So as you can see, significant variability, and this is what we address, and that's why bringing a more unified terminology is very important. So we have a proposed definition. This was actually taken from Dr. Wendy King, who'd done work up in Pittsburgh about this, but really to look at weight recurrence as a percentage of maximum weight loss. So the weight recurrence being the patient's current weight minus their nadir weight, their lowest postoperative weight. So how much weight, what's the delta that they have recurred? And then divide that by the maximum weight loss. So their initial weight minus their nadir weight, so the total weight loss that they've experienced after their intervention, and get a percentage of that. So a 5% maximum weight loss, a 10% maximum weight loss. So that was somewhat of a more unified, more standardized definition that hopefully can be adopted and used to create standardization of how we look and treat patients. And then looking ahead, thinking about fellow mindset, academic mindset, what can we do with this? So we have to determine at what percent maximum weight loss should we intervene. So is a 5% maximum weight loss physiologic after surgery, or is that enough to consider it pathologic that we need to intervene? And do we need medical therapy? So is the the realm of medical therapy in that 5 to 10%, and then surgical therapy above? Is there a role for surgical therapy in some patients when we look at a weight perspective at that 5%? So these are questions that we should be looking towards to answer in the future. So how do you work up a patient with weight recurrence? So of course, an accurate history, figure out their starting weight and their weight naters, and whether it's one or more than one. They may have lost weight and then recurred and then lost weight again and got to a lower point. It's important to kind of recognize where those deltas are. Any subsequent interventions, did they have an endoscopic dilation? Did they have plication? These sort of things. It's important to know what's been done since that initial surgery, and then review the operative reports. As an example, I had a patient who I initially was working up for a vertical banded gastroplasty, and even on my own endoscopy, that it looked like a variation of that, a little different. And then literally at their preoperative appointment a week or two before surgery, they provided me with the paper operative report from 30 years ago that said it was actually a non-adjustable band with a very wide kind of horizontal staple line as opposed to a vertical staple line. And that's really was kind of a last minute piece of information that was very important in figuring out the best therapy for this patient. And then of course, a metabolic, environmental, and behavioral assessment similar to our workup when we initially work up patients for surgery, but oftentimes can be more intensive, especially in the behavioral side of things. If you're concerned about patient compliance, if you're concerned about environmental factors negatively impacting your patient's weight experience, that behavioral assessment might need to be more than just an initial screening. And then evaluation of the patient's anatomy. So an endoscopy to determine anatomic factors. As an example, this patient clearly has some retained fundus. As you see, there's two different calibers, a wider caliber, more proximal to the narrower sleeve lumen. And then as you can see, there is spiraling of the sleeve lumen as well of the staple line. So that's an important factor when preoperatively working up patients, so you know what you're getting into and you know how best to approach things. And then upper GI can also be very helpful. Here you can see opacification of both the pouch and the remnant stomach, denoting a gastrogastric fistula. And this is actually not a stock photo. This is one of my patients, again, because we're doing so many revisions that eventually you get something that's an interesting picture. So, and I think what may be the most important part of the workup is the informed discussion with the patient goals and expectation settings. For me, honestly, is really the most important. It's what I talk to my residents about. All the things we talk about getting to surgery. Surgery is fun, surgery is exciting, surgery is important, but getting to surgery and getting the patient to surgery, both from a medical workup, but as well as getting the patient in the right place with regards to expectations and goals is very important. This discussion is important at each point of contact with the patient. The initial visit, when you kind of introduce the idea of revisional surgery to them, maybe dispel some bad information that they've gotten elsewhere or found on the internet. Following the workups, you've done your endoscopy, you've done your upper GI, you have a better understanding of their anatomy. Again, having that informed discussion with the patient. And then that preoperative visit leading up to surgery, it's important to know that they know what they're getting into. And what to expect, and from a bunch of different perspectives. So the variability of weight loss outcomes, I tell all of my patients that I can, I give them a number and I give them percentages, but I say patients do vary. Some patients don't have that same dose response to the second time around surgery. Their body physiology just doesn't respond the same way as they did the first time, even if they had an initial success after their first surgery. I talk about the increased risk profile of revisional surgery. What I like to spell it out in layman's terms for my patient, I give them a 90-10 rule, where I say, 90% of these patients are more difficult, whether it's scar tissue adhesions, whether it's variable anatomy, working around an old staple line. But I say 10%, can be easier, but you have to make it real for them to say that there is a significant increased risk, not a worrisome risk, but something that is significant. And then the potential for unanticipated findings. So having a good plan B, C, etc. You get in there, you find something that even with the workup, you may not be able to see. So knowing what's next. And then the insurance approval process, as we all struggle through, unfortunately, and it varies state to state. The concept of one bariatric surgery per lifetime. Patient, when the medical directors will say weight recurrence is not a complication, and then sometimes providing patients with more rigorous extra requirements to be able to get approved. And just looking, at the resources of the ASMBS, this is an excellent review of reoperative bariatric surgery. Reviewed 175 articles over 15 years for our most common surgeries. It noted that most were single institution case series. We just don't have very large series of reoperative bariatric surgery, but I'm sure at this point, as we're doing more and more, that will come into play. And the conclusions were that reoperative surgery is safe and effective with the appropriate patient selection and an experienced surgeon. So getting that experience, relishing the experience you're getting in fellowship and then taking that out into practice will make you a safe and effective reoperative bariatric surgeon. So just briefly kind of touching on different options after weight recurrence. I'm not going to get into the technical nuances. That's something that each one of you in your fellowship will learn very thoroughly. And then you'll go out and kind of figure it out for yourself, as I did. I was doing things the Duke way for about a year, I would say, and now I think it's my variation on the Duke way as I've seen more and more reoperative surgery. So following lap band, we have generally our three most common surgeries. We have three main options, and this is just kind of a broad overview: band to sleeve, band to bypass, and band to switch. So the band to sleeve, of course, is technically simplest of the three. Sleeve gastrectomy can be done for higher risk patients and therefore, decreased operative time, decreased anesthesia time. The downside, however, though, is you're potentially stapling across that old band site, which is a scarred down area, which may be weakened. There may have been ulceration or erosion that needs to be addressed. So that does confer an increased risk, and being the most proximal, that can increase your risk for leaks after this sleeve. And it may not address the band-related issues. So I know we're focused on weight recurrence here, but patients with the band oftentimes will present with reflux, dysphagia, and whatnot, and the tight, high-pressure sleeve may not really address it and actually may exacerbate it, so something to consider. Band to bypass, which generally is the more common revision after band. It is a little more technically complex, of course, but it allows you to really staple distal or proximal to that band site and avoid the scarred down area, especially after taking down the gastroplasty. And of course, just like the bypass does address reflux, it does also address those other upper GI symptoms related to the band. And then band to switch, similar gastric considerations from a technical perspective to band to sleeve, of course, because you are doing a version of the sleeve gastrectomy at the stomach. And again, it may not address the band-related issues in that same way. And nutritional support may be more complex. So the patient probably has developed maladaptive eating after having their band, and then addressing that as well as a significantly malabsorptive procedure may be a little more complex in the patient. And of course, with the bypass and the switch, we're also talking about mini gastric bypass or OAGB, and the switch also refers to the SADI as well. And that's more of a personal preference, I'm sure. And then following sleeve gastrectomy, similar sort of options in a different sort of light. So we again go down to sleeve, bypass, and switch, but the sleeve to sleeve is known colloquially as re-sleeve. Unfortunately, has poor long-term data. It's just not a great option. It hasn't really borne out well in the literature. And there's really no physiologic change. So oftentimes what you're doing, you're seeing patients with weight recurrence, they've had the physiologic positive impact initially after their surgery, and then something has happened or multiple things have happened. You want to do a physiologic change. You want to do some sort of different operation to them to see if that may better improve their weight loss experience and then, decrease their risk of weight recurrence following your second intervention. And of course, re-sleeve does also refer to endoscopic methods as well, plications and whatnot. But again, the data is just not there to the ASMBS, and currently does not recommend this as a second procedure. And just, as an example, there was a short series a few years ago, for patients with retained fundus or dilated sleeve that did show 62% excess body weight loss at just under 2 years, but did have a significantly higher complication rate. And, I would wonder to see about the long-term data on that, weight loss experience. And sleeve to bypass, which is probably our more common experience, and definitely my common experience here, can be technically challenging to determine the perfusion of the pouch and the remnants. So looking at a part that's already been stapled, that blood supply has already been removed from, and then managing that prior staple line, that neo greater curve staple line, being able to make sure that your new staple line, your new anastomosis, is well away enough to not compromise your new anastomosis from an ischemic perspective, which may bear down the road as marginal ulceration or something like that. However, it does address that post-sleeve reflux, which a lot of patients with post-sleeve weight recurrence will present with in conjunction. And finally, the sleeve to switch makes sense. It's the first step to the switch anyways. You do have to address, though, the sleeve caliber, because the caliber of the sleeve in the switch is a little wider. Now, that can be helpful if there is some retained fundus or dilation, and maybe a positive impact of that complication after sleeve. And then the recognition that the switch or even the SADI is not necessarily available in many regions and may not be an option for most patients. So with that, I'm going to turn it over to Dr. Majid. Thank you very much.
Okay, thank you, Matt. That was awesome. Just want to make sure I am sharing my screen. Start share. Can you guys see it? Give me a thumbs up. Okay, awesome. Great. So first of all, I want to thank Kanur and her entire team for taking the lead on this and in giving me an opportunity to talk about this topic, especially in front of fellows. It's a big privilege and honor. I think it's really exciting to talk about this with people who are the future of our field. So very grateful for the opportunity. Surgical treatment, a weight recurrence following bariatric surgery. It's a little bit about myself. I have nothing to disclose. The objectives that were given to me were surgical options for weight recurrence following gastric bypass, following SADI or DS, and the outcomes of revisional procedures performed for weight recurrence. So my talk is going to be broken down into 3 sections based on these objectives. This is how I feel most of the time when I'm doing revisional surgery. This is also how I felt when I saw those objectives. I tried to convince Kanur to change at least one of the 3, but she said, no, I'm stuck with them. 50%, I think, Matt, that was a great idea to share a little bit about your practice setup. I did not think about that, but more than 50% of my practice is now revisional surgery and has been for many years. And I am in solo practice. So all that figuring it out, how to troubleshoot, what if I get stuck in a problem, is constantly on my mind, which is probably why I look like this guy. So surgical options, we're going to first talk about following gastric bypass. My talk is going to be more technical, but I did want to have a little broader perspective. I was reflecting on my practice for 12 years, the significant number of revisional surgery that I've been doing, not by choice, but I've started to enjoy that. And I'm pretty sure that most of you guys would be encountering it, whether you want to do it or not. So it is challenging. It is increasing in number. There is currently no standardized approach. There are multiple factors that lead to weight recurrence after bariatric surgery, and therefore the approach has to be a multidisciplinary approach. And I'm not going to elaborate more on that. That's not my topic right now. There are anatomical considerations you have to have. They're physiological. They're patient-related, such as nutritional and behavioral. And after all of this, I would suggest that you ask yourself the question, what objective are you trying to achieve? And have that conversation with the patient and the patient's family. One of the things that I want to emphasize what Matt said is have that discussion, set the expectations right, and set the expectations right with yourself as well. Quite often we try to do things thinking is going to lead to a certain outcome, but it's more of what we want, not what the data or our experience has shown. So, and I'll try to touch upon this or weave this concept to the next few minutes. I chose this table from this paper because I thought it shows very nicely why we have such a high incidence of recurrence after bariatric surgery, and we'll take gastric bypass as that example. So if you see this, patients who've had what they are calling excellent results, which is BMI less than 30. When you do a gastric bypass on a BMI less than 50, in 5 years, 64% are going to, according to this study, had those excellent BMI results. The same category, BMI less than 50 in 10 years, the number goes down to 51. Then when you do the bypass on the super obese, I know it's a technically old terminology, BMI greater than 50, the excellent results of BMI less than 30 are only found in 25%, and that number drops down to 13% after 10 years. So it's a no-brainer that as the years go by, you're going to see more and more people who've had, in this case, gastric bypass, and they have had weight recurrence. So again, whether we like it or not, revisional surgery is going to be part of what we do. I happen to really enjoy it, and I hope you guys will do too, but it does require some thought to be put in. Okay, oh, why am I not? Okay, there. So technical considerations, you have to think about the pouch, the gastrojejunal anastomosis, the roux limb, the BP limb, then there's band over bypass, there's converting bypass to DS. When I'm looking at a bypass patient, these are the thoughts in my mind. What can I do technically? Or not I, but what is available technically that can be done when you're evaluating a gastric bypass patient with weight recurrence. The preoperative workup is extremely important. History is key. Be a good history taker. Find out where their weight recurrence started in their journey. Do your own upper endoscopy. I cannot emphasize that more. Get to know your anatomy yourself. Do an upper GI, I do both. And I look at the images myself, get that operative report, plan and prepare before you go to the OR, and have the realistic and honest expectations that I think we've already talked about. So when you talk about the pouch dilation has been defined in the literature greater than 6 centimeters, greater than 5 centimeters wide. The question is, does size matter? And there's a lot of studies out there that question. How do you measure accurately? I've not been able to measure. I've done thousands of endoscopies, and it's very difficult to measure accurately a gastric pouch. So there is always that rough estimation that you do. And that's why doing your own endoscopies is important. So you have your own little metric or calibration in your brain. Technical options for dilated pouch, operative, endoscopic. We'll talk about it in a little bit. Gastrogastric fistula, there's a 1% incidence. So gastrogastric fistula is not always a result of a complication. It is also a result of how old the gastric bypass is and the territory, the geography where you're practicing. I'm in New Jersey. There were bariatric surgeons who were doing bypasses such that the gastrogastric fistula would be by design. So when I'm evaluating a patient who's had a bypass 20 plus years ago, I'm suspecting it, and I'm going and looking for it because the chances of that fistula being present are very high. How do you diagnose it? I do both, again, the upper GI and endoscopy. And if it's a result of a complication, then yes, it can be a really small fistula, but then does it really contribute to weight recurrence? Since that's the topic we are at, there can be other complications related to gastric fistula. I'm sure you guys are aware of that. What are the technical options of addressing it? Can be both laparoscopic robotic, so in the OR, or endoscopic. I've started doing endoscopic revisions of gastric fistula. Is just so much easier than to take an open gastric bypass, spend hours getting to that fistula, and dividing it. But again, this is something you have to see whether you have the technology available, who's paying for it, and whether this bypass was done open or laparoscopic. Gastrojejunal stoma size. Does size matter? Again, there's been a lot of studies talking about, does size really matter in terms of weight recurrence? Again, my topic is weight recurrence. So does it matter with other complications? That's not what I'm talking about. The GJ anastomosis can be done, as we all know, different ways: circular, linear, hand-sewn. And then with all these different ways, the size that we are creating is different, and the size, what it becomes over time, changes. So when you're evaluating a bypass patient for weight recurrence, do pay attention to the stoma size in front of you, but then weigh that into the overall approach. How much does it matter? The reduction options for pouch and stoma are endoscopic, sclerotherapy, transoral outlet reduction by placing sutures. This has been studied for a long time. I must say that the technology has evolved significantly. My last few bypass, pouch, and stoma revisions were all endoscopic, and I thoroughly enjoyed it. And the patients went home same day, and so far they're doing really well. The cost becomes a factor. You can't really offer it to everybody, and it depends on your local facility and insurance setup. But it is definitely a good option. Laparoscopic refashioning of the gastric pouch. There are different techniques that have been suggested. You can use a 34 French bougie and resect alongside that. You can resect the pouch. Definitely get rid of the blind limb of the alimentary limb anytime you see it. You could revise the GJ, or you don't have to revise the GJ. It depends on how healthy the GJ is. You can plicate it. You can fire a stapler across the pouch and the anastomosis. All of these things all these different options have been done, and they have fairly similar outcomes. I make the decision based on what I find, what I've studied before, and the health of the pouch and the anastomosis as to how aggressive I'm going to be. Some of my references are listed below. This is just a schematic picture of the transoral outlet reduction. Essentially, what we end up doing is creating a teardrop configuration. So you're narrowing or reducing the diameter of the lumen, and you're also plicating the pouch. Banded gastric bypass is another technical option. I have been trained by people who were never a big supporter, so I've personally not done it myself. I think there is some studies like this one showing 28 to 65% of excess BMI loss, such a wide range. Whenever I see a wide range, I want to just highlight what Matt said in his talk about definition of weight recurrence, how it's lacking. Words do matter. The range can really vary based on what the criteria is being used. And so you have to be really smart about interpreting the information correctly and then extrapolating it and putting it to use in your own practice. So I personally don't do banded gastric bypass. I just last week removed a band over a gastric bypass. It was horrific. I think the band on small bowel is just not meant for that. So it's going to slip whenever you leave a foreign body. Don't think it's going to stay there forever. So think about where it's going to go and what price the patient would have to pay for that. Distalization of gastric bypass. Busy slide has been studied extensively. There are two modifications. Let me just see if this picture will make it easier. You can resect the BP limb close to the entero-anastomosis and plug it distally, hence elongating the roux limb, or you can divide the roux limb close to that anastomosis, plug it down and hence lengthening the biliopancreatic limb. I'm going to talk about the concept behind this. When you are playing with limb length, you have to balance what your intended outcome is going to be in terms of weight recurrence with the complications. So make sure you measure your entire small intestine length, especially when you're operating on patients you did not do the primary operation. You don't really know what else was done. Patients, you'll be amazed to find out that they don't really know sometimes, most of the times, what the actual procedure was done. So do your own measuring, your own mapping, and then make a decision of how much common channel length versus root limb versus BP limb. Generally, protein calorie malnutrition is lower when you elongate the BP limb. The BP limb has found to have a bigger role in, plays a bigger role in weight recurrence versus lengthening the root limb. And set the expectations right. In my hands, my experience, the weight loss has been very variable. So it's not consistent. So I tell my patients, we can do it. It's not a problem. And this is, in my experience, has been the range of what I have seen. So you set the expectations right. So they're not like, hey, why haven't I lost the 100 pounds? So, but it's definitely a doable option. Some of my references for that, and I'm happy to share those if anybody needs. Conversion to DS or SADI, technically challenging procedure, can be done in 1 or 2 stages. You would restore the continuity of the stomach followed by the sleeve, and then you would resect the duodenum and create the anastomosis. Again, cannot emphasize enough the significance of measuring the total bowel length. Results in terms of weight loss have been excellent. Complexity of the procedure is probably one of the biggest reasons people don't do it. And there's some complications that patients pay a big price for. I think studying the vasculature of the bypass is very important. I would throw in some kind of a CTA or some kind of a study to really know what is perfused is important, and then using ICG to determine perfusion. Even when you're doing sleeve to bypass, one other thing Matt had mentioned, use that to help you if you have questions about the perfusion. The conclusion in terms of the bypass revision would be that the mechanism that drives weight recurrence after bypass is complex. Patients should undergo evaluation of a multidisciplinary team, and the choice of surgical intervention should be based on the balance between the risks of complications and the extent of weight loss. So be very clear again with what your intent is when you take somebody back for revisional or conversional surgery. Surgical options for weight recurrence following SADI or DS. So this was, I guess, this is my shortest part, but also spent a lot of time trying to figure out if there was good evidence that would answer this question. And the bottom line is there is not much. And the reason why there's not much in the literature is because the incidence of it is low, and also the denominator, the number of these cases that are done is low. I found this study that I thought would be a good snapshot. They did a PubMed search over 30 some years, right? So extensive time period. And they were looking at a lot of outcomes. I just focused on the revision for insufficient weight loss, sticking to the topic at hand, was reported in 0.5 to under 3% of cases. So again, incidence is very low, which is great. When you encounter weight, and I quoted weight regain, I'm a big believer of using the weight recurrence, not regain. When they concluded, in case of weight regain, reducing the gastric volume might be the better first approach than making the small bowel channels even shorter in a DS or a SADI, because again, you have to balance the complication of potential complication of malnutrition and protein calorie and vitamin deficiencies with weight recurrence. So if I have to revise a SADI or a DS, I would rather reduce the gastric volume first before making the small bowel channels shorter. Outcomes of revisional procedures performed for weight recurrence. This is the third objective. Has been published. There have been countless publications on this topic, but they are not all the same. It's comparing apples to oranges. And I'll circle back with what Matt had said in the beginning of how the terminology is all over the map, the definitions are all over the criteria is all over the map, because we don't have a standardized definition. So with that mindset, I want to focus on this one particular meta-analysis and systematic review, which I thought was very interesting, published this year. And what they did was they focused on postoperative morbidity and weight loss after revisional bariatric surgery for primary failed restrictive procedure. So again, please do not use the word failed, but for the talk, but that's their title. So I have to use that. This was the methods and search strategy. For the interest of time, I'm going to skip this. Bottom line is they did an extensive literature review. They had a pretty good criteria of inclusion, and these forest plots, and I'm going to try to simplify this busy slide. They're looking at these procedures compared to sleeve gastrectomy. They're using sleeve gastrectomy as a comparison because, let's face it, it is the most commonly performed procedure in the US. Is greater than 50% of our bariatric procedures. So gastric bypass was the gold standard. I think now sleeve gastrectomy is not the gold standard, but it is the most frequently performed procedure. So I think it's fair to compare outcomes with the procedure that is being done most frequently. So in terms of weight loss outcomes, let's focus on C and D, which is total body weight loss, since that's what we want to train our brain to look at, and not just excess weight loss. And you'll see that 1 year post-op versus 3 years post-op, the procedures that have had the most weight loss are kind of the same. Bypass, followed by one anastomosis, gastric bypass, followed by SADI, followed by DS. In other words, SADI and DS have better total body weight loss outcomes after revisional bariatric surgery, when these procedures are performed as a revisional bariatric surgery for weight recurrence 1 and 3 years post-op, compared to the bypass and OAGB. This is just a slide explaining it in numbers. For the interest of time, I'm going to go to the next slide, but I'm happy to take any questions and go back to that busy slide again. Then they looked at weight recurrence after revisional procedures. So, how do these procedures do in terms of weight loss? Now, how do these procedures do when done in a revisional setting in terms of weight recurrence after these revisional procedures, which I thought was very interesting. So this forest plot was based on 13 studies, and you'll see that SADI did better than the DS, better than the bypass, better than OAGB. And they have listed down below the odds ratio. Then they looked at morbidity. How do these procedures perform in terms of morbidity, both less than 30 days and greater than 30 days? So the BPD no-brainer has the highest morbidity, followed by DS, followed by bypass, under 30 days, as well as under greater than 30 days. So yes, these procedures have better weight loss outcomes, less weight recurrence, but higher less than 30-day and greater than 30-day morbidities. So how do they, based on their systematic review and this analysis, how do they look at BPD, DS, and DS without the BPD as a revisional procedure? Emphasizes the supremacy of these procedures in terms of both percentage excess weight loss and percentage total body weight loss 1 and 3 years out. Is not the best performing operation. DS is not the best performing operation with regards to the risk of weight recurrence, and no data were available to estimate this outcome for BPD. Compared to sleeve gastrectomy, complication rates are higher. When planning a revisional DS or BPD, the risk of major complications must be evaluated alongside the advantage of the rapid and conspicuous weight loss. They also looked at sleeve gastrectomy as a revisional procedure. So if they use the term secondary sleeve gastrectomy when it's being used as a revisional procedure, it does guarantee the lowest rate of complications, but also the least amount of weight loss in terms of total body weight loss and excess weight loss 1 and 3 years post. So again, important to think about this. Important to have the expectation right. Just because it's technically something you're comfortable with doesn't mean that's what you should favor or present to the patient without being objective with the outcomes. These data may suggest that sleeve gastrectomy should not be considered when planning revisional bariatric surgery other than in exceptional circumstances, especially in cases of primary failure for insufficient weight loss or weight regain. I put it in quotes. I did the failure and regain in italics because those are the terms I don't think we should be using, but that's what the study used. Bypass is a revisional procedure. It is most frequently performed conversional procedure after primary restrictive surgery. So both with the band and the sleeve, I think Matt mentioned that as well. Cannot justify this approach as the benefits in terms of weight loss of revisional bypass are limited compared to sleeve gastrectomy. I think we all know that. Outcomes at 1 and 3 years from revision, the main difference was just minor, 4.68 versus 7.3. It is more frequently associated with early and late major morbidity. And one of the things you have to keep in mind is when the sleeve is being converted to a bypass for the indication of GERD, how to interpret those results in terms of weight loss separate than doing the procedure primarily for weight recurrence. OAGB and SADI, their conclusion was it was the most balanced procedure. When they use the word balance, they're balancing between weight loss outcomes versus complications. SADI is also a significant increase in percentage excess weight loss after 1 year, while the difference is not significant for OAGB at this time point. I know that one anastomosis gastric bypass in the US is still new, and we need more of our own data to kind of concur with this or not, but that's what's out there right now. The limitations of this study they were all retrospective. And then again, I'm highlighting that the absence of homogeneity and the definition of weight regain as an indication of revisional surgery and the inclusion of patients who underwent this procedure for primary surgery complications. So again, as we come up with a better definition, will these things change? Most likely, but that's what we have right now. So just keep that in mind when you're interpreting this data. And then they did not talk about the quality of life of these patients undergoing the surgery, such as with malabsorption and reflux. In summary, I think revision or conversion for bariatric surgery, especially for weight recurrence, is complex, but I find it fascinating. You have to balance between the weight loss and the complications. Think through, plan, and set the expectations, and then have fun. Do not run away from these procedures. Go in there and you'll figure it out. but just don't go in there without having a plan. And just because you can do it doesn't mean that you should. So keep that in mind always. With that, this is my team and this is my contact information. Thank you. I think it's finished on time. Yeah.
Thank you so very much. Those are two fantastic presentations. It's always a humbling topic to go into clinic and have several patients who've had weight recurrence and trying to come up with what's going to be best for them, because there's so many different options and it's different, I think, for many of the patients we see. We have a few questions in the chat that I'd like to pose to both panelists. And really the first question, excuse me, is probably for Dr. Davis, but it would be great to hear both your opinions. So many definition, excuse me. Is there a role for creating a longer BP? Actually, this is really for Dr. Majid, I apologize. Is there a role for creating a longer BP limb if there's a BMI of greater than 50?
I'm not muted, right? Yeah. Yes. So we are talking about as a primary operation when you're doing the bypass primary. Yes. So
yes, ma'am.
So that's one of the tables I had showed that when the starting BMI in a primary operation is less than 50 versus greater than 50, the outcomes of these procedures change, and therefore in terms of weight loss. So when you're starting off with a higher BMI patient, which means greater than 50 in this case, then yes, you should plan to do the most aggressive weight loss approach, which means, well, for bypass right now, make sure you're sizing your pouch, you're making it smaller, and your BP limb is long, which means I do greater than 100 centimeters for that.
Thank you. And then another question that we had in the Q&A is, what would be the revision options after an endoscopic sleeve gastroplasty? Would you recommend a bypass only, or could you do a sleeve?
Yeah, great question. So I guess I'm getting old because I have done a few of these and I was never obviously trained for this. So what helped me was it was a female, did the workup, because the stitches in this endoscopic gastroplasty are not always going to stay the same. So every approach has to be different. So you have to do your endoscopy. In her case, there were these metal, the needle fasteners sticking out in different places. One part looked larger than the other. It was like, it was interesting. So,
hey, Saniea, I'm going to share screen of some pictures I recently took of an ESG. And Shana, I know you've got to run, so if you have to hop off, thank you so much. But I do think this is an important thing. Can you guys see those pictures?
Yeah.
Yep.
Okay, so I think you can see here kind of the fasteners that you're talking about. I think this may give the fellows a little bit more.
Yeah, perfect. Yes, thank you. So I kind of studied that preoperatively as a separate procedure, not at the time of the case. And then I literally just basically mapped it out, and I explained to her that this is where we are at. We are going to go in and find out how we are going to navigate through those, take whatever we can out endoscopically, endoluminally.
Hey, Dee, can you hear me okay?
You're still on here, Shana.
Oh, I'm sorry.
No worries.
So you want to take out whatever you can endoluminally, same concept if the band is kind of eroded intraluminal, you use your tools to remove whatever you can endoluminal. And so it's a combined laparoendoscopic case, and then scrub back in laparoscopically. And I did a combination of stapling where I could, imbricating, plicating where I could, with the goal of ultimately reaching that 40 French, bougie size for your sleeve. The patient did great. It took much longer. So it can be done. You just have to really think through and map it out and make sure that you have a way to get rid of those metal fasteners and do not fire the stapler over it. If they're stuck, you cannot do it, just imbricate.
I think one other thing or a couple of things, if you're doing this laparoscopically and you want to scope intra-op before you decide what you're doing, make sure you put a bowel clamp on the ligament of Treitz. Make sure you're using CO2 and not air so that you don't have quite as much long-lasting insufflation. And then the other thing to note is that a lot of the physicians, providers who are doing these, you can see this is majority the body and the antrum. So the fundus is often relatively spared. And so when I was talking with this patient, we kind of went over her pictures and I said, I can do a sleeve, but you can see kind of distally in the antrum there, I am going to have to go out and carve out some of that stuff. Alternatively, her fundus is wide open and free of any sutures, any fasteners, any anchors. And so we actually decided that she's going to be a revision of bypass, and we're just going to kind of leave all of this in situ. So that's another conversation to have.
Right. But you know what I'm like, at least in New Jersey, patients, they're very difficult for them to agree to a bypass. Everybody's had now some experience negative, and you can't, and that's one of the challenges when you go out into practice, is like you have to balance what they are comfortable with as well. So you're right. Bypass would be a simple, you just stay way above all the fasteners, you do what you need to do. But if that's what the patient does not want, then what are you going to do?
Yeah, luckily we're still bypass friendly here in North Carolina. It has its downsides, I think. And as we become more comfortable with SADIs and DSs, we are doing more of those for the kind of higher BMI patients. But yeah, it definitely depends on the culture and trends in your area.
I think, Dr. Majid, you bring up a really important point. The data out that we have helps with that probability discussion. And sometimes they're which can take a long time. And as I feel like the more experienced I've gotten, that maybe I've innovated that conversation a little bit, but trying to manage those expectations so that you can use more tools in your armamentarium doesn't always work. And I think it's really important that your patients are part of that. You have a shared decision-making model. But I think weight recurrence is one of the toughest conversations because of some of the preconceived notions that exist, not only with weight loss surgery, but outcomes, recurrence, and then what are our options and how good they are the second go around. There was one other question in the Q&A, and then Dr. Jane Spangler, I'm going to have to jump off. I apologize. I wanted to make sure we got to it. It's a little bit of a different question, but it was asking if you're revising a bypass for weight gain or other symptoms, is there any benefit to resecting the candy cane?
Yes. Candy cane is not part of the normal anatomy of a bypass. So whenever you see one, I would recommend just resect it. Even if the patient does not have symptoms, if you're there, we should resect it. And that basically means, dissecting everything around it. I always leave, I scope a lot in the case. So I will advance my scope into the rulim and then just use that as a bougie. And it's a very simple transaction. But I would really encourage everybody to look for that candy cane and resect it when you're there.
Matt, do you have any thoughts on that? I mean, I think for me, weight recurrence, I don't traditionally associate with candy cane. If I'm already doing something, I often will resect it if it is large, but I do think for chronic nausea, vomiting, people who you worry have Bezor type symptoms, things like that, it's definitely something to consider. Your thoughts?
And I think I definitely agree with Dr. Majid that it doesn't belong. I think also just when you think about older procedures and differences in training and technique, some people will note on their op note 150 centimeter rulim, and then the candy cane tape will be 50 centimeters. So that's something to consider, because whether it's a tension issue, whether you go a little distal in your room to make your anastomosis, that may have been why, but ultimately your numbers may not bear out, and that may be an important thing to look at. And so remeasuring is really, really an important aspect. And also just knowing the previous surgeon's technique, because if they did a circular stapler, likely they've already resected that. It's not something you'd find there, but you should definitely anticipate it if they did a linear or handstone fashion.
Great points.
Yep.
Well, you guys are rock stars. Fantastic lectures. Thank you so much. I look forward to seeing you both, hopefully in the near future, but take care.
Thank you so much for the invitation.
Just heading to a fun revision.
Bye.
Thank you, Saniea. I'm not sure if we're live or not. I think we're live. Julie, hi, how you doing? Thank you.
Good.
We're still waiting on Matthew. Thank you for all the fellows for joining us. I truly enjoyed that talk. I know it's not an easy talk, especially with the lack of data and the fact that the data is all over the place and everyone is doing something a little bit different in their practice depending on local expertise and the kind of support that we have. We have a few questions in the chat box, but before we go over those questions, the one question I have for you, Saniea, is, keep in mind you're giving a talk to fellows who are still in training. As of next July or August, they'll be looking for a new job somewhere. And there would be like the most junior faculty in private practices or large academic institutions. So what kind of advice do you have for the fellows in terms of doing those complicated cases? I always tell the fellows, don't even attempt to do those complicated cases early on before you gain some experience and you have the support staff in place and you have some experience tackling those very complicated cases. Obviously, if you're in a private practice, it's a very sticky situation because, like you said, you may not have that kind of like support and backup from a more senior person. Obviously, if you're in a large academic institution, more senior physicians may be able to help you and bail you out, if you will, if you have a complication or if you have a problem. But what kind of advice do you give for fellows who are about to go into practice, they're finishing their training? Those cases we know are very complicated. They can be very cumbersome and very lengthy.
Absolutely. I think it's a very good question and very apt. And that's one of the reasons why when Kunur asked me, I said, are you sure we want to talk about surgical options for weight recurrence after DS? I mean, that's just a whole different level. So I think that regardless of which setting you go into, whether you're academic or community-based private practice, the principles of thinking through, being prepared, should remain the same. You don't want to just rely on somebody who's going to bail you out because you don't know whether that person has the expertise with that particular scenario. Because let's face it, bariatric surgical from a technical perspective has changed a lot. Right now, very few anastomotic cases, more robotic, less laparoscopic, forget about open. So everybody now comes with a little different experience level, even if they've been out in practice for a few years. But I cannot agree with you more. Do not attempt to do these cases by yourself. Always ask and plan to have help there. Even if you think it's a simple conversion, there's no such thing as simple. I just last week removed a band over a bypass and it was horrific. So even now, like years later, you find yourself in situations you're like, what would be really good to have an extra pair of hands. So I think the key is in preparation and always asking for somebody to be there, scrubbed in. And if you don't need that person, great. But if you need that person and the person is not there, then that's just a sticky situation. But generally, I think avoiding revisional operations will be difficult if you want to focus and build bariatric surgery into your practice. I think embracing it is important. Double scrubbing, even if you're not going to be billing for it, even if it doesn't convert into RVUs, look at that as an extension of your training. The more you see, the more you do, the more comfortable you're going to feel. So always have somebody with you, and there you'll be amazed that even in private practice settings, there will be people who will be willing to help. You just might have to schedule the case not around your convenience, but on their availability. Yeah,
very good points. We're all seeing a very high number of revisions and conversions and corrections and stuff like that. The one question we have, and I'll open that to you and Matthew as well. Matthew just joined us. Somebody's asking about distalization as an option for weight gain after a gastric bypass. I know there's a lot of talk about the way the distalization is currently performed, and we talk about the toll and the length of the common channel. What's your experience with distalizing Roux-en-Y gastric bypass, and what kind of weight loss are you seeing with those patients?
Right. So my personal experience has been unpredictable. So I'll go and do the same technical operation like I attempt to with measuring the small bowel. There's always a little bit of did I really measure it exactly the same way every time? But now I have like my set graspers. I always mark it the same way. I always measure it the same way. So I'm trying to like minimize the variability, but the weight loss is not predictable, which makes it very difficult to have that conversation with the patient in the office, because you can't really set the expectations accurately. What I just say to them is there's a range. You could lose as little as 30 pounds, or you could lose as much as 80 pounds, because that's the range I've seen. And then I do practice the multidisciplinary approach in terms of regardless of which surgical procedure I'm doing, which means that they all have to work with the dietitian. We have a low threshold of starting patients on weight loss medications. But from a distalization bypass standpoint, I have seen weight loss every single time, but sometimes it's as little as 30 pounds. Then you think
Saniea,
about what's the...
Sorry, are you lengthening the roux limb, or are you lengthening the BP limb? Because I know there's
BP
different
limb.
ways of doing the BP limb. Okay.
I'm lengthening the BP limb, and for two reasons. One, because we have learned now that the BP limb has a more significant physiological role in weight than roux limb. And the second thing is the protein calorie malnutrition is less noted with lengthening of the BP limb, and that I'll go down to 150 centimeters or more. As long I like Higa's paper where it says make sure you have at least 400 centimeters where the food goes through, and if I have 400, then I don't worry about the rest.
Okay, Matthew, what's your experience with distalizing Roux-en-Y gastric bypass?
So I think distalization is a great opportunity to give a patient an effective surgery when everything looks fine up top at the gastrojejunectomy. So patients will, colloquially say that their pouch is stretched. That's what they feel, and these sort of things. In the workup, it doesn't seem that way. You go in and there's really not a lot you can do with the GJ. It's the right size. The pouch is the right size and shape. But we can do something distal to really increase the malabsorptive aspect of things. Now, an important point for me, I don't do DS in my practice because we just don't have the setup from the ancillary aspect of things. So doing a distal bypass in my practice is very different because my dietitians aren't familiar with distal malabsorptive procedures. So I have to have my patients come in more frequently, really have to be on top of them about that in order that they make sure that they don't have any malabsorptive issues. So that's just a consideration for me. And also because of that, my technique is to go longer with the common channel to not risk getting too close to the TI and therefore having significant malabsorptive issues that may not be able to be managed well within my hospital system.
Do you guys find that there are certain patients who you would consider to be ineligible for a limb lengthening procedure?
Yes, and a compliance, and if they don't like to take pills, they will drop hints. You can pick these things up. I'm not a pill taker. If they're compliant with vitamins or not, and if they've had obviously a bypass already, and they come in with vitamin deficiency, that's obviously a contraindication. So you have to have a very clear, strict criteria before you include them and give them that option. It's a great question.
The other thing I would like, and I love the fact that both of you, Saniea and Matthew, have touched upon that, and it's a good point for the fellows to keep in mind when they go out there and either join like a well-established practice, or maybe start their own practice, or maybe join an academic institution, is that I cannot overemphasize the need for a multidisciplinary team to take care of those patients. At our institution, we have a 3-month and 6-month medical weight loss. That's a requirement for weight regain before any kind of revision. Obviously, the use of medical weight loss, adjuvant pharmacotherapy is a big deal now, and this is something that changed our practice. Sometimes those patients are put on anti-obesity medication for a few months to see how they're doing, because like you said, Saniea, I like the fact that you said that sometimes that weight loss, especially after devising a gastric bypass, is unpredictable, meaning it's not very consistent even when you do the same thing. You use the distalization example. I can use the example of revising the pouch. Sometimes I get 60-70% pounds weight loss post-op, and sometimes I get no weight loss, even though I'm making the same size gastric pouch. So the use of adjuvant pharmacotherapy, the use of a multidisciplinary approach for taking care of those patients, whether it's medical weight loss, behavioral counseling, dietary counseling, is truly necessary, not only to basically screen those patients pre-op, make sure there's no dietary indiscretions, no behavioral issues, but also to continue to take care of those patients post-op.
And I think that's an important point as well, just because the medical weight loss pathway has many more touch points than our surgical pathway. If we're seeing patients annually, they're seeing them quarterly, sometimes even monthly. So it allows you to really be on top of those patients. And like Dr. Majid said about compliance, about recognition, picking things up, if you give them this pre-operative, pre-revisional medical weight loss period, that allows you to kind of really get a feeling for the patient's compliance and the patient's, commitment to this second operation.
So there's one more question from the chat I would like us to touch on. I know we're a little bit over time. But someone has asked about the insurance authorization process to get coverage for weight recurrence and doing these different operations. How have you guys navigated that?
I don't know, Matt, if you want to go first, or I can.
Yeah, I'm happy to. We have an interesting, I would say every 6 months something new comes up in the insurance exchange. We have just, the Blue Cross of Tennessee just deemed all bariatric surgery outpatient eligible in our state. So that's another fight that we're having, but it's really hard to convince people who don't live, obesity management about the importance of what we do, and, the importance of second operations as, part of the continuum of obesity. They get stuck on these, one operation per lifetime policies, or they deem the patient non-compliant or ineligible without any real, understanding of what we do. So it's a lot of appeals and peer-to-peers, and really just making the being an advocate for the patient. And I think the other thing is that do an extensive workup and maybe try and pick up on something that may be considered a complication to allow you to slide through the insurance exchange either, whether it doesn't have to be a GG fistula, but it can be ulceration or other sort of things that are more surgically correctable, and that oftentimes will get us through the insurance process a little easier.
Right. Insurance coverage is state specific, so I just wanted to make sure that all the fellows knew that. So what might work in one state, maybe where you're doing a fellowship, might not work where you end up practicing. So keep that in mind. So you have got to know your statewide coverage. And then the insurance policy does change at least once a year. So just because it was a certain way a year ago doesn't mean that it's going to stay the same. So these are the things, the lessons I learned the hard way in practice. And I think what Matt said, do a very extensive workup is key. Hit them with so many points. We are the expert, they are not, right? So we hit them with so much information that, and if they deny it, we get on a peer-to-peer. I do my own peer-to-peer. As busy as you are, take that call. You should know your patient anyway, and then you just hit them with all that data points. And then I also think that advocacy hat is important as the driver of when they present ridiculous hurdles, like blood pressure is defined. If you're on 3 blood pressure medications and your numbers are consistently 180, well, in the world of telemedicine, how many people are actually coming and getting their blood pressure checked? So there's always something that you can kind of argue reasonably without being unprofessional, but that has to come from a place of care and advocacy, and that comes when you really know your patient. And let's face it, some patients are not I shouldn't say worth, but they haven't earned that place of getting a revisional operation because they haven't done their part. So make sure they've also done their part. They are engaged in their journey, which means I have my patients call the insurance company and say, I've done XYZ, why are you denying my operation, right? So I'll have them get engaged, I'll write my appeal, and then, we kind of fight it out together. I've had appeals that have taken 6 months, but we have not given up. If a patient has earned that, then I just keep fighting, and the patients will keep fighting with you. And 6 months later, we've gotten it approved. So there's always something, but don't give up. That's the bottom line.
That's a very good point, Saniea, because sometimes you have to go the extra mile for your patient and make an effort to try to help them out, because you're the patient advocate. And this is something that our fellows see in our practice every single day. We go the extra mile to try to get those patients approved for sure. Now, for the sake of time, I'm going to have to end it here. Thank you so much. This was truly an amazing take on a very complicated subject. Saniea, Matthew, very nice seeing you. And thank you for all the fellows for joining us. And hopefully we'll see you again next month.
Thank you, guys.
Bye.